Welcome back. Today we're plunging into one of the most urgent and frankly complex areas in infectious disease, how we actually treat meningitis with drugs. Now, if you're not familiar, meningitis is basically inflammation of the membranes around your brain and spinal cord. Sounds straightforward maybe, but it's really not. This thing is fast, it's brutal. We're talking shockingly high mortality rates, severe long-term disability. Even in the best hospitals, it's a true medical emergency, a minute-by-minute race against the clock and a huge test for modern medicine. Okay, so let's unpack this. We've got a stack of global guidelines, clinical reviews, some really cutting-edge research papers here. Managing meningitis, well, it's complicated. Geography matters, bacterial resistance is evolving like crazy, and then there's that big hurdle, the blood-brain barrier. Our mission today really is to give you a shortcut. Synthesize the latest evidence, dissect this huge threat of antimicrobial resistance, or AMR, and explore some, frankly, revolutionary new ways researchers are trying to get drugs where they need to go.
That's absolutely essential. We're looking at, putting together what the global guidelines, WHO, IDSA, ESCMID, are saying and where the research is actually heading. The foundation is still urgent antimicrobial therapy. Get those drugs in fast. But like you said, the field is moving beyond just, killing the bug. Researchers are now laser focused on how to protect the brain itself. From the damage, the massive collateral damage from the infection, and maybe even more importantly, from our own immune response.
Yeah, the coordination here is pretty remarkable, isn't it? You've got these big international players, WHO, IDSA, ESCMID, CDC, all trying to get on the same page for standard of care. And despite, local differences we'll get into, the absolute baseline everywhere is urgent empiric antimicrobial therapy. Patient comes in, you suspect meningitis, you treat first.
Right.
Ask specific questions later. Speed saves lives, full stop.
And setting that global baseline, well, the biggest recent development has to be the 2025 WHO guidelines. These are really pivotal, not just because they exist, but they're the first ever comprehensive global guidance for community-acquired meningitis. And importantly, they're specifically designed for low and middle-income countries, LMICs.
Why is that LMIC tailoring so critical?
Well, because that's where the highest burden of disease is, right? They often struggle with diagnostics, consistent resources. It's a different reality. So the WHO framework gives this universal starting point for suspected acute bacterial meningitis. First-line empiric defense, intravenous ceftriaxone or cefotaxime, third-gen cephalosporins.
Okay, powerful, broad, relatively affordable.
Exactly, a reliable place to start. And it all feeds into that wider defeating meningitis by 2030 roadmap.
But the WHO focus isn't just on the immediate crisis, is it? They're looking beyond survival.
That's a huge point. They explicitly recommend formal audiological screening hearing tests and comprehensive rehab services after the illness. It's recognizing that, survival isn't the whole victory. The battle is against long-term disability, hearing loss, cognitive problems that can ruin someone's life long after the infection's gone.
So putting that post-acute care into the global guidelines, that's a big policy shift.
It really is.
Okay, now let's look at the guidelines from places like North America with IDSA and Europe, ESCMID. We start seeing this universal framework adapt, right, to local threats. IDSA, for instance, immediately splits things. There's community-acquired bacterial meningitis, CABM, and then this other beast, healthcare-associated ventriculitis and meningitis, HABM.
And that distinction, it changes everything because the likely bugs are completely different. So in the U.S., for standard CABM, the empiric treatment is that cephalosporin plus vancomycin, that addition. Non-negotiable there.
Why Vanac specifically?
It boils down to resistant streptococcus pneumonia, PRSP. The prevalence of penicillin and even cephalosporin-resistant pneumococcus is just too high. If you skip the vanc, you risk treatment failure against a resistant bug, and the consequences catastrophic.
Right. And ESCMID in Europe, they hammer home the urgency antibiotics within 1 hour of arrival.
Extreme urgency.
And they also tailor. They advise adding vancomycin or rifampicin in areas with high resistance, similar to the U.S., but they also flag adding ampicillin for certain groups.
Yes, that ampicillin addition is crucial. For everyone over 50 or anyone immunocompromised, it's necessary to cover Listeria monocytogenes.
Listeria?
Yeah, it mainly hits the very old, the very young, or people with weakened immune systems. Both ESCMID and WHO really highlight that risk factor, often overlooked but critical.
Okay, and finally the CDC. Their focus seems a bit different, more public health oriented.
Definitely. While they reinforce prompt treatment, absolutely, their guidance leans heavily on proactive stuff. Routine vaccination, MANI-CWI, Menin-B, pneumococcal, and secondary prevention.
Secondary prevention meaning?
Post-exposure prophylaxis. PVP, for close contacts of someone with a confirmed case, usually a single shot of ceftriaxone or maybe oral ciprofloxacin.
And that stops outbreaks.
It's been incredibly effective, but, and this is a big but we'll get to with AMR, even those reliable PPP drugs are starting to see resistance popping up in Neisseria meningitidis, a worrying trend.
Okay, so pulling this all together, what's the main takeaway for our listener here?
The key takeaway, the aha moment, is that these differences aren't contradictions. They're necessary adaptations. It's a sophisticated, layered approach. The universal framework, get that third-gen cephalosporin in fast, has to be tweaked based on basically three things. Local resistance data, which bugs are common in that specific region, and patient factors, age, immune status, travel.
Right.
Precisely. Context is everything.
Let's dive deeper into the actual drug choices for bacterial meningitis. We keep saying golden hour. Start empiric therapy immediately.
Because delay is the single biggest predictor of a bad outcome, death or disability. The absolute priority is starting those antibiotics ASAP. Ideally, yes, you get blood cultures, you do the lumbar puncture for CSF before the first dose.
But sometimes you can't, right? Maybe the patient needs a CT scan first.
Exactly. If there's any delay, maybe looking for a brain bleed or swelling that makes the LP unsafe, you draw the blood cultures and the antibiotics go in immediately after that. You cannot let diagnosis delay treatment. It's a potentially lethal trade-off.
Okay, let's break down the empiric drug choices. This is where age and immune status really dictate the cocktail.
It's all about predicting the most likely pathogen. And age is the biggest clue there. So for neonates, brand new babies, 0 to 4 weeks old, we worry about bugs they picked up during birth. Listeria monocytogenes, group B streptococcus, and also gram-negatives from the gut, like E. coli, Klebsiella. So their regimen needs ampicillin specifically for Listeria and group B strep combined with cefotaxime, or sometimes an aminoglycoside like gentamicin. Broad coverage is key because their immune system just isn't fully developed.
Okay, neonates covered. Then the main group, adults under 50. Healthy-ish adults.
Yeah, the workhorse category.
Yeah.
Here, it's overwhelmingly S. pneumonia and N. meningitis, the two classic culprits.
So the regimen is?
Cephalosporin plus vancomycin. Again, that vancomycin is there purely because of potential penicillin-resistant pneumococcus. If it turns out the bug is susceptible later, you might drop the Vanic. But you absolutely must cover that possibility up front.
Got it. And then the third critical group needing an extra drug, older adults, over 50, and anyone immunocompromised.
Yes. Missing the step can be fatal. They need the standard cephalosporin plus vancomycin, plus the non-negotiable addition of ampicillin.
Why ampicillin again here?
Listeria. The risk of Listeria monocytogenes just skyrockets in this group. And Listeria is naturally resistant to cephalosporins. So if you forget the ampicillin, you're leaving them wide open to a killer bug you could have easily treated.
Okay, that stratification makes sense. Now, what about the really tough one? Healthcare-associated meningitis, HAVM. This isn't your typical community bug.
No, completely different scenario. This is often someone who got meningitis after brain surgery or head trauma, or maybe they have an infected CSF shunt or drain.
So the bugs are different.
Totally different and much nastier. These are typically multi-drug resistant, hospital-acquired organisms. So the empiric therapy has to be different too. You need vancomycin still for gram-positives like staph, including MRSA, but you pair it with an anti-pseudomonal beta-lactam.
Meaning drugs like
Cefixime, ceftazidime, or a carbapenem like meropenem.
Why specifically anti-pseudomonal?
Because the likely culprits are often those hardy hospital water bugs, Pseudomonas aeruginosa, Acinetobacter species. These guys have complex resistance mechanisms, terrible susceptibility profiles. You need the big guns immediately.
And you mentioned earlier, it's not just about drugs with HAVM.
Absolutely critical point. You often need source control. If there's an infected shunt or hardware,
Great.
it usually has to come out. Biofilms form on those devices, and IV antibiotics alone just can't sterilize them. You have to remove the source of the infection.
Right. Makes sense. Okay, so that's empiric therapy. Once you get the culture results back with the bug identified and its sensitivities, the goal is to tailor the treatment, right? Pathogen-directed de-escalation.
Exactly. Precision medicine. If you find out it's N. meningitis and it's fully susceptible to penicillin, great. You can de-escalate, switch back to simple penicillin G or ampicillin. Cheaper, narrower spectrum, less resistance pressure.
But what if it's the opposite? What if the S. pneumoniae comes back highly resistant?
Then you confirm you're on the right track. Maybe even intensify. If the minimum inhibitory concentration, the MIC, for the cephalosporin is high, say 1 microgram per ml or more, you stick with the combination, cephalosporin plus vancomycin. And in really tough cases, you might even consider adding rifampin to boost killing power in the CNS.
Speaking precision, let's talk duration, because the old rules seem to be getting challenged.
Yeah, the traditional dogma was pretty rigid. 7 days for meningitis, 10 to 14 days for S. pneumonia, and at least 21 days, 3 weeks, for listeria or gram-negatives.
But that's changing.
There's a big push from antimicrobial stewardship. A really important systematic review came out in 2024. It suggested that for uncomplicated bacterial meningitis in kids caused by the usual suspects, shorter courses, maybe down to 7 days, could be just as effective as a longer 10, 14-day regimens.
Wow, that's a potentially huge shift. 7 versus 14 days. That's fewer side effects, less time in hospital, less chance of driving resistance.
Exactly. It's a big deal if it holds up in broader practice. And this move towards precision also highlights something else becoming more important: therapeutic drug monitoring, or TDM, especially for vancomycin.
TDM, measuring the drug levels in the patient's blood, right? Why is that so crucial for in meningitis?
It's necessary because vancomycin is, well, it's a big molecule. It doesn't cross the blood-brain barrier very well, even when the meninges are inflamed and leaky. The IDSA guidelines actually specify a target. We need to achieve vancomycin concentrations in the CSF that are 10 to 20 times the MIC of the bug we're treating. That's a really high target.
Why so high?
To overcome that poor penetration, we need to be absolutely sure we have enough drug at the site of infection in the brain and spinal fluid to kill the bacteria effectively, not just enough floating around in the blood. Without TDM, especially for a critical infection like meningitis, you could easily be underdosing, giving a subtherapeutic level in the CNS, and that leads straight to treatment failure.
Okay, let's shift gears. Bacterial meningitis is the big killer, but what about viral and fungal causes? The treatment approach is totally different, right?
Completely different. Viral meningitis is actually the most common form overall.
But usually less severe.
Generally, yes, fortunately.
Yeah.
Most cases, often caused by things like non-polio enteroviruses, are self-limiting. They get better on their own in about 7 to 10 days. So the treatment is basically supportive care. Fluids, fever reducers, pain management. Let the immune system do its job.
And this brings up a really important point about antibiotic stewardship.
Absolutely critical. If you strongly suspect viral meningitis, maybe the CSF fluid analysis points that way, lots of lymphocytes, normal glucose, negative bacterial cultures, you must stop the empiric antibiotics you likely started.
Continuing them does no good.
Worse than no good, it does harm. It drives resistance, increases the risk of side effects like C. diff colitis. There's no benefit and real potential downsides. Stewardship 101. Stop unnecessary antibiotics.
Okay, but there are exceptions where you do need specific antiviral treatment, right? The herpes viruses.
Yes, huge exception. If you suspect herpes simplex virus, HSV, or varicella zoster virus, VZV, the chickenpox shingles virus, you need intravenous acyclovir immediately.
Even if you're not sure it's spread to the brain tissue itself, causing encephalitis.
Yes, start it on suspicion. Acyclovir is relatively safe and can be life-saving. It works by specifically targeting the viral DNA replication. Don't wait for confirmation. And there's a specific situation, Malloret's meningitis, which is recurrent meningitis, usually caused by HSV2, where taking oral acyclovir or valacyclovir long-term can actually suppress those debilitating recurrences.
But sadly, for the most common cause of viral meningitis, those enteroviruses, we don't have a specific drug.
No targeted treatment, unfortunately. There was some research investigational work on drugs like plecanaril years ago, but nothing ever got approved or made it into practice. It's a major gap. For most viral meningitis, it's still just supportive care.
Okay, shifting again. Fungal meningitis. Now we're talking really complex, often long treatments, especially for cryptococcus.
Yes, Cryptococcus neoformans is the most common fungal cause, mainly hitting immunocompromised people, particularly those with advanced HIV/AIDS. And the classic treatment strategy, based on the 2010 IDSA guidelines, is, well, it's a marathon, a 3-phase marathon.
Okay, walk us through the phases.
Phase 1 is induction, 2 intense weeks. The cornerstone is intravenous amphotericin B deoxycholate, the standard formulation, plus an oral antifungal, flucytosine. This combo is highly effective at clearing the fungus fast.
But Ampho B, that has a reputation, doesn't it?
Yeah, a nasty one.
Mm-hmm.
Standard amphotericin B is notoriously toxic to the kidneys. It requires really intensive inpatient monitoring, checking kidney function, electrolytes, magnesium, potassium, daily, sometimes twice daily. It's tough on the patient, tough on the system.
Okay, so after 2 weeks of that.
Phase 2 is consolidation, typically 8 mgs. You switch to high-dose oral fluconazole, much easier to take, less toxic. And then phase 3 is maintenance. This can last a year, sometimes longer, depending on immune recovery. It's low dose oral fluconazole just to prevent the infection from relapsing.
That whole process, induction with toxic IV drugs, intense monitoring, sounds incredibly difficult, especially in the low-resource settings where cryptomeningitis is most common.
Exactly. It's a huge burden. Which brings us to the game changer, the 2022 WHO update for crypto management in resource-limited settings.
What did they change?
This is a massive win for global health equity. Recognizing the toxicity and logistical nightmare of that 2-week IV Ampho B induction, the WHO endorsed a radically simplified preferred regimen. It's a single high dose of liposomal amphotericin B that's safer, lipid-based formulation given once at 10 mg/kg. That single dose is combined with the standard 14 days of oral flucytosine and oral fluconazole.
So one injection instead of 14 days of toxic infusions.
Precisely. Liposomal Info-B works because it packages the drug in fat globules, basically. This directs it away from the kidneys, reducing toxicity, and targets it better to fungal cells. Studies showed the single high-dose regimen had comparable efficacy, similar survival rates, but with substantially less kidney toxicity and a vastly simpler delivery. It's potentially transformational for high-burden countries.
That's incredible. Are there other fungal causes we should quickly mention?
Yeah, briefly, there are rarer but often very difficult to treat molds. Aspergillus meningitis might require voriconazole, which itself needs drug-level monitoring due to variable absorption and interactions. Coccidioides meningitis, common in the U.S. Southwest, often needs lifelong high-dose fluconazole. And really concerningly, we've seen recent iatrogenic outbreaks infections caused by medical procedures or contaminated products, like Fusarium meningitis linked to contaminated spinal injections. These can hit immunocompetent people and often require complex, prolonged combination antifungal therapy. Fungal meningitis remains a major challenge.
Okay, this next part gets to the heart of the problem in bacterial meningitis. You called it the double-edged sword. We need antibiotics to kill the bacteria.
Right, but when those bacteria die, they release all these highly inflammatory components, bits of cell wall, toxins, and that triggers the host's own immune system to go into overdrive. It's trying to clean up the mess, protect the brain, but the response itself becomes massively destructive.
So a lot of the long-term damage isn't directly from the bacteria, but from our own response to them.
Exactly. The brain swelling, the edema, the inflammation of blood vessels, vasculitis, which can cause strokes, and perhaps most crucially, the neuronal apoptosis, programmed cell death, leading to cognitive problems. A huge chunk of that is collateral damage from the host inflammatory response. So we're desperately trying to do damage control.
And for decades, the main tool for damage control has been corticosteroids, specifically dexamethasone.
Dex is really the only adjunctive therapy, something given in addition to antibiotics, that has solid evidence behind it. But, and this is key, that benefit is very specific, the strongest evidence. It significantly reduces mortality and bad neurological outcomes, but mainly for pneumococcal meningitis in adults, S. pneumonia. It also used to dramatically reduce hearing loss in kids with H. influenza type B or Hib meningitis. But thankfully, the Hib vaccine has made that incredibly rare in most parts of the world now.
And with Dex, the timing is everything, right? You can't just give it whenever.
Absolutely critical. It must be given before or at the same time as the first dose of antibiotics, ideally maybe 10-20 minutes before.
Why the urgency?
Because you need to blunt that initial inflammatory surge that happens when the antibiotics start killing bacteria and they release all those inflammatory molecules. If you wait hours, the cascade is already running wild and the Dex has much less impact. You have to get ahead of it, not chase it.
Okay, but this creates a tricky situation, doesn't it?
Oh.
Especially in places like North America or Europe where vancomycin is standard empiric therapy.
Yes. The great vancomycin-dexamethasone controversy. It's a real clinical dilemma. Dexamethasone works by reducing inflammation. Part of that means it helps tighten up the blood-brain barrier, make it less leaky.
Okay.
But vancomycin, being a large molecule, relies on that inflammation-induced leakiness to get into the CSF in decent concentrations.
So the Dex that's helping reduce inflammation might actually be hindering the Vanac from getting to the infection site.
That's the concern, yes.
Right.
Are we potentially undermining our key anti-resistance drug, vancomycin, by giving dexamethasone, which might reduce its penetration into the brain?
So what do clinicians do? If you suspect pneumococcus, you want the Dex benefit, but you need the Vanac to work.
It's a difficult calculation. In areas with high pneumococcal resistance, clinicians might still give Dex for the proven mortality benefit in adults, but they're acutely aware of the potential impact on VANIC levels. It makes things like therapeutic drug monitoring for vancomycin even more important in those patients. You're trying to ensure adequate CNS levels despite the Dex.
And you mentioned the benefit of Dex might be less clear in LMICs.
Yeah, the data is inconsistent. One theory is that patients in lower resource settings often present much later in their illness. By the time they get to care, the inflammatory process might already be so advanced that giving Dex at that point doesn't provide the same benefit as giving it early. The window might have closed.
It sounds like Dex is helpful, but very specific and comes with baggage. Have other adjunctive therapies been tried?
Oh, yes. The history books are littered with failed attempts, but none failed quite so spectacularly or alarmingly as glycerol.
Glycerol. What was the idea there?
Glycerol is an osmotic agent. It draws water out of tissues. It was thought that giving it orally might be a simple, low-cost way to reduce brain swelling, intracranial pressure in meningitis, especially attractive for resource-limited settings. Early, smaller studies looked kind of promising.
There's always a but.
But then came the large, well-designed, randomized controlled trials, the definitive evidence. And it wasn't just neutral, it was bad. The most pivotal trial done in Malawian adults with bacterial meningitis had to be stopped early by the Data Safety Monitoring Board. Not because glycerol wasn't working, but because it was actively harming patients.
Harming them how?
The group receiving glycerol had a statistically significant increase in mortality. Their death rate jumped to 63% compared to 49% in the placebo group. A huge difference.
Wow. 63% mortality.
Right.
So the treatment itself was killing people more often than placebo.
That's what the data showed. It was a stark, sobering result, proven potential for harm. So glycerol is absolutely not recommended. Off the table.
Any others that failed?
Yeah, things like paracetamol, acetaminophen for fever control specifically in meningitis, therapeutic hypothermia, cooling the body, antioxidants like N-acetylcysteine. None have shown consistent benefit in rigorous trials for improving major outcomes like death or severe disability. It really leaves dexamethasone as the only adjunctive player with proven, albeit limited, and pathogen-specific benefit.
So controlling the inflammation is tricky, which really puts all the pressure back on the antibiotics. But you mentioned AMR, antimicrobial resistance.
Okay.
Is the huge looming crisis here.
It's arguably the single biggest threat to effectively treating meningitis moving forward. It complicates everything. Your initial empiric choice, the dose you need, how long you treat, even our ability to prevent outbreaks with prophylaxis, it's rapidly evolving.
And it's not just the usual suspects, the tough hospital bugs. Resistance is showing up in pathogens we used to think were easy.
Exactly. Take Neisseria meningitis, the meningococcus. For decades, it was reliably susceptible to penicillin, and ciprofloxacin was the gold standard for preventing spread to contacts, the PEP.
But that's changing.
That era seems to be closing. Since around 2016, we've seen this worrying global uptick in isolates that are fully resistant to penicillin, sometimes carrying enzymes called beta-lactamases that chew up the antibiotic. And perhaps even more concerning for public health, we're seeing increasing resistance to ciprofloxacin. That directly threatens PEP. If your main tool for stopping outbreaks starts failing, that's a major public health problem.
And didn't you mention a specific case in the U.S. where this became a reality?
Yes, a landmark case reported in 2020. The first documented case of meningitis caused by a strain of N. meningitidis that was both beta-lactamase producing, meaning resistant to penicillin ampicillin, and resistant to ciprofloxacin.
Perfect storm.
Pretty much. Resistant to the first-line treatment and the first-line prophylaxis. It meant clinicians had to rely solely on broad-spectrum cephalosporins, with no option to de-escalate later. It's a stark warning that resistance isn't just a gram-negative issue. It's hitting our core meningitis pathogens.
Okay, what about the other classic culprit, Streptococcus pneumonia? That's the bug that drove the addition of vancomycin in the first place, right?
Correct. The high prevalence of penicillin-resistant S. pneumonia, PRSP, is the constant background noise, the reason vancomycin is routine and empiric therapy in many places. And if the lab confirms high-level resistance, typically defined as a cephalosporin MIC of 1 microgrammole or higher, then combination therapy is absolutely mandatory. Cephalosporin plus vancomycin. And if the patient is really sick or responding slowly, some experts advocate adding a third drug, like rifampin, just to maximize the killing effect within the CNS. You can't afford to fail against resistant pneumococcus.
All right, but the real nightmare scenario, the toughest fight, is usually with those multi-drug resistant MDR, gram-negative bacilli, the ones causing HAVM, healthcare-associated meningitis.
Yeah, that's where things get incredibly difficult. We're talking about organisms like Acinetobacter baumannii, Pseudomonas aeruginosa, and CREs, carbapenem-resistant enterobacteriaceae.
Why are they so tough in meningitis?
It's a double whammy. First, many of our best antibiotics against these bugs penetrate the blood-brain barrier poorly. Second, these organisms often carry multiple complex resistance mechanisms and enzymes that destroy drugs, pumps that spit them back out. Meropenem, a carbapenem, is often a go-to if the bug is susceptible. But once you have resistance to carbapenems, you're really running out of options fast. You might be forced to consider the polymyxins colistin or polymyxin B. These are old drugs brought back as a last resort.
And using polymyxins for meningitis, that introduces another layer of complexity, doesn't it, because of that poor CNS penetration?
Exactly. You often can't rely on giving them intravenously like other antibiotics. They just don't get into the brain well enough. So treatment frequently requires direct intraventricular or intrathecal administration, delivering the drug directly into the CSF space.
How is that done?
Either through an existing external ventricular drain, an EVD, which is a tube placed surgically into the brain's ventricles, common in neurocritical care, or sometimes via repeated lumbar punctures, injecting the drug directly into the spinal fluid.
Wow, so you're bypassing the bloodstream entirely. That sounds invasive and requires specialized care.
Highly specialized. It moves the whole treatment paradigm from standard infectious disease care into the realm of neurosurgery and neurocritical care. It's complex, carries risks of secondary infection from the procedures themselves. It really underscores the desperation when facing these MDR gram-negative infections.
So the takeaway for treating suspected HAVM is:
know your local enemy. Empiric therapy must be guided by your local institution-specific antibiogram data. You need to know what resistance patterns look like in your hospital's Acinetobacter or CRE isolates. Waiting for culture results when dealing with these bugs could be fatal. You need your best guess up front based on local data.
Okay, so AMR is a huge threat. Older drugs have limitations. But the research community isn't standing still. This is where things get really exciting, looking at innovation. Let's start with tuberculous meningitis, TBM. Still a massive global killer.
Devastating disease, high mortality, severe disability, and the standard treatment takes 9, sometimes 12 months. Grueling. But there's a major trial ongoing, Imagine TBM, testing a fundamentally shorter, more intense regimen, aiming for 6 months of treatment instead of 9-12. If successful, that would be revolutionary for global TB control.
6 months?
Yes.
How are you trying to achieve that? Better drugs? Higher doses?
Both. It involves using high-dose rifampicin and high-dose isoniazid, 2 standard TB drugs, but pushed higher for better CNS penetration. And crucially, they're adding linezolid.
Linezolid. That's not a typical first-line TB drug, is it? Why linezolid?
It's chosen specifically for its excellent CNS penetration. Linezolid is an oxazolinone. It's relatively small. It's fat-soluble lipophilic. It gets into the brain much better than many older antibiotics. The idea is that by combining these intensified doses with a drug known to reach high CNS concentrations, you can kill the TB bacteria faster and more effectively, allowing for a shorter overall treatment course without sacrificing efficacy. Big potential impact.
Okay, shifting to antifungals. We talked about the single high-dose liposomal ampho-B. Any other breakthroughs on the horizon?
There are a couple of promising avenues. One is otosaconazole. It's a new oral azole antifungal, currently in phase 2 trials, specifically designed to tackle fluconazole-resistant cryptococcus. That could fill an important gap. But the one generating maybe the most buzz, the potential holy grail for managing invasive fungal infections, especially crypto, is oral amphotericin B, specifically a formulation called MAT2203.
An oral version of ampho-B. We just talked about how toxic the IV version is and how liposomal helps, but an oral form that works.
That's the goal. MAT2203 uses a novel lipid nanocrystal technology, basically tiny lipid particles that encapsulate the ampho-B, allowing it to be absorbed orally and critically seem to reduce its toxicity significantly. The key NSET trial tested it for cryptococcal meningitis induction in HIV patients. The results suggested comparable efficacy and survival to the standard IV ampho-B regimens, but with dramatically less kidney toxicity and obviously much easier administration.
Wow. An effective, safe, oral amphotericin B, that would be transformative, right? Especially where IV access and monitoring are difficult.
Absolutely transformative. It could revolutionize treatment, adherence, access, feasibility, a massive leap forward if it pans out in further studies and gets approved.
Okay, these new and repurposed drugs are exciting, But maybe even more conceptually interesting is this idea of host-directed therapies, HDTs, targeting our own response, not just the bug.
Exactly. This is a major shift in thinking. Instead of just trying to kill the pathogen faster or harder, HDTs aim to modulate the host's immune response to be less damaging, less collateral damage, and a potential advantage. It's less likely to drive antimicrobial resistance because you're not directly pressuring the bug to evolve.
Dexamethasone is sort of a crude HDT, right?
Kind of the original blunt instrument HDT, yes. But researchers are looking for more targeted approaches, and some involve clever repurposing. For example, there's an ongoing trial looking at adding daptomycin to standard antibiotics for bacterial meningitis.
Daptomycin. Isn't that an antibiotic mainly for gram-positives like MRSA? Does it even get into the brain well?
Not particularly well, no, and that's the point. They're not using it primarily for its antibacterial effect in the CNS. They're investigating its potential anti-inflammatory and immunomodulatory properties. Using an antibiotic as an HDT, it's a fascinating concept.
That is, yeah, next level thinking. Are there other future HDTs being explored?
Preclinical work, yes. Things like highly targeted immunomodulators. For instance, looking at inhibitors of specific parts of the inflammatory cascade, like complement C5 inhibitors. The complement system is a key driver of inflammation and tissue damage and infections. Targeting it precisely might protect the brain while the antibiotics do their work. Still early days, but very promising direction.
Okay, but whether it's a new antibiotic, a repurposed drug, or a fancy HDT, none of it matters if it can't get past the BBB challenge, the blood-brain barrier. Let's really break down why this is such a fortress.
It really is a physiological fortress. It's mainly formed by the endothelial cells lining the brain's capillaries. But unlike capillaries elsewhere, these cells are fused together by extremely tight junctions. Think of them as molecular rivets, sealing the gaps between cells, preventing things from just leaking through paracellularly. On top of that physical barrier, the endothelial cells are packed with efflux pumps, proteins like P-glycoprotein. Their job is basically to recognize foreign chemicals, including many drugs, especially antibiotics, grab them and actively pump them back out of the brain cell and into the bloodstream.
So it's a wall and it has bouncers throwing things out?
That's a pretty good analogy, yeah. It makes getting drugs in at high enough concentrations and keeping them in incredibly difficult.
So how do you breach the fortress? Brute force doesn't seem to work well.
Right, so the clever approaches involve tricking the barrier or finding alternative routes. This is where nanoparticle drug delivery comes in. We're talking tiny carriers, maybe lipid-based like liposomes, or polymer-based nanoparticles that can encapsulate the drug.
And sneak it across?
The really sophisticated approach is the Trojan horse strategy. You engineer the surface of the nanoparticle, you attach specific molecules, ligands to it, maybe something like transferrin, which the brain normally takes up for iron transport.
Ah, so you disguise the nanoparticle as something the brain wants.
Exactly. The nanoparticle, wearing its disguise, binds to the natural receptors on the brain endothelial cells like the transferrin receptor. The cell then thinks, oh, here's some transferrin I need, and actively engulfs the entire nanoparticle through a process called receptor-mediated transcytosis. It actively transports the Trojan horse, drug and all, right across the barrier and into the CNS.
Turning the barrier from an obstacle into a delivery mechanism.
Precisely. It's hijacking the brain's own natural import systems. A really elegant solution, conceptually. Phenomenal research going on there.
Are there other ways being explored, maybe non-invasive?
Yeah, a couple of other interesting angles. One is intranasal delivery, trying to get drugs directly to the brain by bypassing the BBB via the olfactory and trigeminal nerves in the nasal cavity. Some small molecules might travel this route. And then there's focused ultrasound, FUS. This uses targeted sound waves from outside the head, non-invasively. These waves can temporarily and locally disrupt those tight junctions in a specific brain area.
So you briefly open a little window in the BBB?
Essentially, yes. While that window is open, systemically administered drugs given IV that normally wouldn't cross well, can flood into that targeted brain region at much higher concentrations. Then the barrier closes back up. It's a way to enhance delivery of existing drugs, potentially. Still experimental, but very exciting.
So we've covered the fight against the infection itself. But as we wrap up, we have to talk about the aftermath, the real definition of a cure. Because just surviving meningitis often isn't the end of the story, is it?
Sadly, no. Clearing the infection is often just the first battle. The incidence of permanent neurological problems, sequelae, is disturbingly high. Depending on the bacteria, the patient's age, how quickly treatment started, somewhere between 1 in 3 and maybe even 1 in 2 survivors of bacterial meningitis is left with some kind of lasting issue.
That's a huge number. What are the most common problems?
The most frequent is probably hearing loss, affects maybe 10 to 30% of survivors. It's often due to direct damage to the auditory nerve or structures in the inner ear from the inflammation during the acute phase. This is exactly why those new WHO guidelines are pushing for mandatory formal hearing tests after meningitis. If you detect it early, maybe interventions like hearing aids or even cochlear implants can help.
Okay, hearing loss. What else?
Significant cognitive deficits are very common. Problems with memory, concentration, executive function planning, organizing. This can be absolutely devastating, especially for children. It can impact their entire educational trajectory, their future life. And then you have physical problems too. Epilepsy, seizures developing later on, motor deficits, weakness, spasticity, problems with coordination, and even things like cerebrovascular complications. The inflammation can damage blood vessels, leading to strokes either during the acute illness or later. The damage can be profound and widespread.
This really highlights a critical gap, doesn't it? We have antibiotics, we have Dex for one specific bug, but we don't have anything to fundamentally protect the brain cells themselves during that acute storm.
That's the holy grail right now. The desperate need for effective neuroprotective therapies. Drugs we could give alongside the antibiotics and Dex, specifically aimed at preventing neuronal death, preventing cochlear damage, shielding the brain from that inflammatory onslaught. We currently have nothing proven in that category. It remains the single biggest unmet need in meningitis care. Survival without disability has to be the goal.
So pulling everything together, the guidelines, the AMR threat, the research frontiers, what are the absolute key strategic imperatives for the clinician at the bedside and for the researchers?
Okay, for clinicians, I'd say 3 things. First, data integration. Don't just follow a generic guideline blindly. You have to integrate your local, up-to-date AMR data into every single empiric antibiotic choice, especially for suspected HAVM. Know your hospital's bugs. Second, optimize adjuncts. Stick rigidly to that dexamethasone timing before or with the first antibiotic dose when you suspect pneumococcal meningitis in adults. It matters. Maximize the benefit you can get. And third, systematize follow-up. We need to universally adopt that WHO recommendation, build systems to ensure every meningitis survivor gets formal audiological screening and neurological follow-up. Catching sequelae early is crucial.
On the research side, where should the focus be?
Pushing on HDTs. Find ways to safely modulate that damaging host response. Translate the nanotherapeutics and FUS delivery systems from the lab into human trials. Get those drugs across the BBB. Find broad-spectrum antivirals, especially for enteroviruses, and fundamentally discover and validate those neuroprotective agents. That's the path forward. The challenge is huge, but honestly, the pace of scientific innovation right now feels faster than ever. Hashtag, outro. So, if you look at the whole picture, the trajectory, the foundation for acute care, the basic antibiotics, it's strong. But that foundation is being seriously eroded by AMR. And that pressure is forcing the field towards these really radical innovations. We talked about things like oral amphotericin B, host-directed therapies, new delivery methods, trying to stay one step ahead.
And the ultimate goal has shifted, hasn't it? It's not just about keeping the patient alive anymore. It's about survival with minimal, ideally zero, disability. So what stands out to you listening to all this incredibly complex, high-stakes fight? Maybe the key to finally defeating meningitis, getting to that 2030 goal, it isn't just finding one magic bullet drug. Maybe it's about how we master the combination, how we successfully navigate that formidable blood-brain barrier, and how we learn to protect the brain from the very defenses that are supposed to save it, ensuring patients don't just survive, but survive whole.